Okay, welcome. Good evening. Thank you all for joining us. My name is Amanda Rabluski, and I am the program coordinator for the Pillar program at Boulder Community Health. And thank you so much for joining us for our lecture tonight on addiction treatment. Where do I start? So for those of you that aren't familiar with the Pillar program, we are part of BCH, and what we do is help folks get connected to treatment for substance use disorders or chronic pain management without the use of narcotics. Hence the topic of our presentation tonight, managing and navigating where to start with addiction treatment for yourself or potentially a loved one. As usual, just a little bit of housekeeping first. The format for tonight's lecture will consist of the lecture portion, which will last about 40 or 45 minutes. Afterwards, we'll use the remaining time to answer your questions. So please type your short, general questions in the chat box to the right of your screen, and we will get to them as we're able. We might not be able to answer all of them, just depending on time. And you can enter your questions in the chat at any time during the lecture. You certainly don't have to wait until the end. If we don't get to your question, or if more come up after you watch this lecture, there will also be a resource slide at the very end of the presentation. So please feel free to reach out to any of the resources listed there. We're always happy to talk more with folks and to provide more information. And second, again, I always want to express how much I appreciate those of you that are tuning in live or watching the recording. It helps support our programming, and it's so refreshing to see how many people are interested in the information that we present here on our lectures. These are big topics we're talking about: public health, public safety, mental health, addiction. So I appreciate you spending your time with us this evening, or if you're watching the recording after the fact. Because you're all here and because you're showing support, I like to be transparent as well and set an expectation for what this lecture will be. And I always start with what it won't be. So what this will not be is a cure for your individual situation or an easy answer to the huge issues that are public health, substance abuse, mental health struggles, chronic pain, all of the above. What it will be, though, is an opportunity to learn more about all of those issues and a way to learn how to address something and start on a journey that may lead to healthier choices and healing. So, and as always, a message of hope that recovery is possible, and there's a huge community out there waiting to help support people on their journey to recovery and sobriety. So, all that being said, I would like to introduce tonight's speakers. From AspenRidge Recovery, we welcome Danny Filippo, licensed practicing counselor and licensed addictions counselor, as well as Steve Sarin, manager of public relations and marketing. We'll do a quick switch and they will take it away. Thank you.
All right. So, are we good to go? Awesome. I'm Danny, by the way. You probably could tell by the name Danny that person would have long hair, and Steve would be the guy without it. So, probably didn't need to be explained, but now you know. Danny, Steve. And so, thank you for joining us tonight. And I am really, really passionate about the topic of addiction. Really look forward to engaging. And with whatever questions come up, just know that, if I don't know the answer, if Steve doesn't know the answer, we'll also work on finding the answer. So, to get us started. Oh, and I guess that also tells who's who. So, the big question of what is addiction? So, we took this from National Institute on Drug Abuse, and it starts with a chronic relapsing disorder. And so, I want to just break this down. Of chronic relapsing, what that means is this is an ongoing fight. For people who experience addiction, this isn't something where it just goes away. It's, I've gotten sobriety and I am no longer experiencing addiction. It doesn't necessarily work like that. It's viewed more in the medical community as something along the lines of asthma or diabetes. So, right, I'm an asthmatic. And so that is a chronic relapsing disorder that I have, where over time things happen and there's a flare up. And that's what they're saying for that part of it. And then it goes on to start about the compulsive drug seeking. And this part is really, really important. We'll talk about more later how substance use, abuse, dependence, all those things, different variations of substance use can be problematic. And when we talk specifically about addiction, there we really have entered the realm of compulsive use. And so it really becomes this part of a feeling of I have to do this. And when I encourage people to think about what they maybe know about obsessive compulsive disorder, where someone is, okay, just to stay safe, I need to flick a light switch 3 times and then I know that I will be safe. And it is that type of compulsion that people may experience during a craving. And so it goes on about the harmful consequences. So anytime that we're working with a diagnosis, it does need to be something that is creating conflict within their lives. And it does happen despite the fact that the consequences are there. And I'll talk more on that later. The long-lasting changes to the brain. And so with that, this is really where it goes to, as I said, there is a medical model of addiction, and I align with it. Not everyone does, and I'm also not going to ask you to align with it. What I ask people to do is open their mind to the idea that there are chemical changes and functions in the brain that are changing, specifically with the dopamine reward system. There are a lot of things going on with it, but that specifically, it gets hacked. And when it gets hacked, it's overstimulated, and it does become that compulsive piece. It becomes a survival piece. Because of this aspect that the brain is changing in the way in which it would normally function, it is considered a brain disorder, and it also is a mental health condition. And when I say that, that means like we have a diagnostic statistic manual, the DSM-5 that we refer to. And that diagnosis criteria is not referred to as addiction. I'll talk about it a bit more later, but is referred to as substance use disorder. So on that note, addiction is a very broad field, is the right way to say it, I think. And interestingly, as I said, when we talk about it in the DSM-5, it's not necessarily talked about in the same way here, where we talk about spectrum of addiction. But while there may be varying language, I do think the language that's used throughout it can be really helpful. And so I really like this diagram. Use is really, it's kind of this fish would pair with a nice white, and you have a glass of wine, and that it's at limited use, and that's really where it is. Misuse steps it up a bit. It is more of I am using for the intention of seeking that high. I am using because I want to be intoxicated. Abuse steps it up a little bit more from there, in terms of it has the frequency that's really happening. And with that frequency, we're starting to see some of the impaired functioning that happens with it. And which I should state, like with misuse, there absolutely can be impaired functioning. Just with the reduction in frequency, it may be less impactful in one's life. Then it goes on to talk about addiction. And another model of this is use-abuse dependence. And this is really like addiction dependence are being used interchangeably here, but it is that I need it. You may hear someone who's addicted to heroin refer to it as getting well when they use. And that getting well, that is coming from this place of, if I don't use, I am so sick. And so it is just turns into the using just to return to normative functioning. And that's what this spectrum is really trying to note. From there, it goes on to, this is like when I'm sitting there and I'm using the diagnostic manual, this is really the criteria. Well, not this, this is the exact criteria that I have to work with. And so I like to go through this one by one, just because it really does a great job in showing the way in which the medical model incorporates into how we understand substance use. So when it talks about taking substances in larger amounts or for longer than you're meant to, that really is that aspect of I've lost control. And that, once again, that hijacking of the dopamine reward system, that is that brain going, okay, I need more, and I've lost my impulse control and my judgment decision making that would help me normally put the brakes on. Wanting to cut down or stop the substance but not managing to. Once again, it's that same concept of, yeah, maybe I need it to get well, right? Maybe we're at that part, or maybe it is in the moment where I'm unable to stop in the moment because I'm just seeking. And so whatever that is, it really does, once again, just tie back to the medical model. Spending a lot of time getting, using, or recovering from use of the substance. So that goes into that impaired functioning that happens that we were talking about in the previous slide with the abuse spectrum. Cravings and urges to use a substance, once again, back from our first slide, that is a compulsion. That is where, once we hijack that dopamine reward center, that our brain is resetting and going, okay, so that's what I always want now. That is what my expectation is. And so once we have that come about, your brain's constantly seeking that. And that reward system, the reality is, it's a survival mechanism. And so it becomes as important as food. And so when we go and it says not managing to do what you should at work or home or school, right? Maybe I'm not getting maybe my partner's really annoyed with me because I'm just not cleaning up my messes whatsoever, and I'm not paying bills on time, or the trash is piling up, or whatever it may be. Those are the ways in which it could start infiltrating and impacting us. And as I said, it could become as important in our brain as food, where it's like, okay, this is what I need to survive. And so once that happens, our valuation, the way in which we evaluate, okay, this is what this is worth in my life, it starts to be thrown off, right? So like, hands down, my wife, my family is more important than substances are to me. But I start to lose track of that in active addiction. And so it goes on, continuing to use even when it causes problems in relationships. Luckily for me, I already brought that in. Giving up important social, occupational, or recreational activities because of the substance use. Once again, that's our valuation system, right? So I love playing the drums. I love playing basketball. I love being with my friends. I love being with my wife. All these things that I would enjoy doing. I love my job. If I'm not showing up to my job, all these things that I'm not engaging in because instead I'm using. Using substances again and again, even when it puts you in danger. It happens very commonly where someone will use, maybe they experience an overdose and people are like, this has to be it, right? The loving family member is like, this has to be the moment. And it may not be. It may not be the message that says to them, okay, I'm going to make change. And once again, it goes back to the evaluation system where the substance is so important that it doesn't necessarily conquer that fear for our own safety. And then continuing to use even when you know that you have physical or psychological problem that could have been caused or made worse by the substance, it really goes along those same lines. Needing more of the substance to get the effect that you want. So we get a tolerance. Like many things in our lives, we build a tolerance to things. And so with that, when we're constantly chasing that reward, we are needing more to try to achieve the reward that our brain is wanting at that point. Then development of withdrawal symptoms, which can be relieved by taking more of the substance. And that is really when we enter into this use and cycle that we get stuck in. And a lot of people have experienced withdrawal symptoms in just terms of, oh, I drank too much and now I'm experiencing a hangover. That's your basics. And the reality is it can get much, much worse depending on the frequency, intensity, and duration which people have been using for, as well as genetic factors that could play a role in that. And the way that it works is as we talked about, there's a spectrum of like use, abuse, dependence. There's also a spectrum in the DSM of like, okay, I qualify for 2 to 3 of these symptoms. They consider that mild substance use disorder. There's 4 to 5, it's considered moderate. 6 or more is considered severe substance use disorder. And there's a term, dual diagnosis. And so this term is thrown around a lot in the addiction field. And quite frankly, it should be, because the reality is it's remarkably important. And dual diagnosis is really this concept that someone has a substance use disorder in tandem with another mental health disorder. So it's a co-occurring, it might be referred to as comorbidity as well. But in short, we have 2 things going on. And so at AspenRidge, we're really wanting to focus on that. It can't just be, I'm just going to focus on the substance use, because it often doesn't address the underlying root issue, right? So let's say, for example, that someone is experiencing depression, and their best attempt in the moment to cope with depression is, I could self-medicate using alcohol. That at least takes away that feeling temporarily. And so they use. And so if we just remove the substance, I'm great, like sober, cool. Like that is important. I don't want to minimize that whatsoever. But it really does become important to address the dual diagnosis, the co-occurring disorder, because often we have a driving force that perpetuates it, that once again, it will make it relapse even more likely. We already know that addiction is a chronic relapsing disorder. It will make it more likely if we are leaving things unresolved. And so very common ones that people may experience. On most common one that I think I see amongst my friend group is your general social anxiety of, going out and schmoozing with people and just having this conversation feels weird. It feels awkward. I would like a little bit of alcohol to help take that edge off for me, because it's going to make me able to cope with that more. And so it's not an uncommon thing. A lot of people do it. And just because you're doing that, if you are, does not mean that you are addicted to alcohol. Doesn't mean that whatsoever. I just try to give that as an example because it's a very common occurrence. And so once again, if anxiety is a driving force, if trauma is a driving force, what I often tell people is, what's going on for you? If you look at your substance use in the context of your life, there's a good chance that it makes a lot of sense and is your best attempt to cope. 2, let's try to find better attempts to cope. Let's figure out how we could do that without a substance. Other things in there, so that should be noted. So males 18 to 44, and I should say, when I was reviewing the PowerPoint, there was a little bit of variance in age. I did see some that were talking about 25 to 50, but roughly speaking, we are talking about this 20 to 50 range of males that are at greatest risk for having dual diagnosis. It is very uncommon that I am treating substance use disorder and there is not a co-occurring disorder. And as it states on this slide, more than half of people who have a serious mental illness are also struggling with substance use. So, levels of care. In short, we have different levels of care because needs vary. People are at different stages of their substance use. So it's really important to just know where things fit in. So it starts off, if we look at the top, that's saying detox and withdrawal management. And so that is usually like medically related. And insurance generally is covering that if we are looking at alcohol, heroin, or opiates, I should say in general, benzos and barbiturates. Those are your biggest risk factors. Opiates, honestly, not necessarily, but barbiturates, alcohol, and benzodiazepines, they're your highest risk for dangerous medical complications during withdrawal. Those are the ones where if someone tells me like, oh, I've been drinking daily for this much time, where I go, we should look at a detox. This way that you have a safe withdrawal and we are setting you up for success. People can have seizures. And essentially, the reasoning behind it is it suppresses the brain so much. They're referred to as depressants. And it depresses them so much that when you remove it, your brain overreacts and people can become prone to seizure, and it can get as serious as death. Heroin withdrawals, opiate withdrawals are notoriously unpleasant, and is part of the reason why that is such a difficulty in terms of gaining sobriety and taking that first step. Then following detox, that step down, what you're seeing is residential and inpatient. And I should also note, generally in detox, people, it seems to be about a 3 to 7 day stay, once again, depending on what their needs are. Residential and inpatient, usually looking at about at a 30-day stay. That's usually the recommendation. And residential is you're in groups, you're there 24/7. They have usually behavioral health techs on site to support the clinicians, and in that you're engaging in a lot of stabilization. Partial hospitalization, that is also very much so a stabilization level of care. The real difference is partial hospitalization is done as an outpatient. So partial hospitalization, you're usually going to be in group for 6 hours a day, 5 days a week, can be more. But with that, while stabilization is really for people who also don't necessarily need to live in their treatment center. So it's kind of that step in between where we're going next, which is intensive outpatient, or referred to as IOP, and residential or inpatient. So partial hospitalization, you may be here referred to as PHP. Once again, length of stay within a partial hospitalization level of care is generally around the 30-day mark. Intensive outpatient, that is usually around 9+ hours a week of group services, and individuals, or of course, individual sessions are incorporated within that. But IOP is, once again, your outpatient, and you don't need necessarily the 6 hours a day, 5 days a week. It's less services and is potentially, just what your needs are, or is potentially the nice way to step you down back into normative functioning in the world. And then that's followed by outpatient, which is generally hour to 8 hours a week, depending on the program. But outpatient is usually, I'd say, more likely in that 1 to 3 hours a group, coupled with some individual work. And so what I also want to note is, while partial hospitalization, intensive outpatient, and outpatient all are able to be done in an outpatient setting, there's also something called sober living. And sober living is not a level of care, but it is an amazing resource. And so one of the things that we do is we partner with sober livings in our community who may be in one of those levels of care, and we also get them the additional aspect of sober living, where it is a commitment to living with other sober people and having some additional accountability, because your environment in recovery is one of the most important things that you can address. So where to start? I know I'm word vomiting, and fortunately you're not here to stop me, so I'll just continue how I word vomit. But where to start? So for individuals, connect with the people that you trust, and this is really hard, especially if you're in active addiction. You may have people in your inner circle that do not have your best interest in mind. It may not be vindictive on their part whatsoever. They may be struggling with substances as well, but they may not be giving you wonderful advice. And we actually just had a group on this, and what we talked about as a group was, we need to look for the people that our values truly align. Like when they tell me something, I notice that, like, okay, their values and my values we're steering in the same direction. And so having that hard look of, like, knowing that, like, who you're seeking support from, I'm also not saying find the person you agree with most. It's a person that you could trust to tell you a hard truth. Another aspect is making the call, picking up the phone, asking for help to pick up the phone. It's a daunting task, and it's a huge task, and it's also a really important one. Another aspect is support groups. Support groups are absolutely amazing. And so there's 12-step, which is like your AA, NA, HA, CA, whatever A. There's a lot of them out there, I promise you. And also, like, they do have a spiritual component to them. Sometimes that's not appealing to people. So I also tell people, I've looked it up. There is 12-step for atheists as well. So don't let that be a deterrent for you. There's also 8-step, which is kind of recovery dharma and refuge recovery, and that's done from a more Buddhist perspective. Smart recovery is more of cognitive behavioral perspective and evidence-based practices. They go from a more psychoeducational approach to a support group. Wellbriety is one for Native American populations. And the Phoenix is an amazing one that is an active, like, let's go climbing, let's go for a run, let's do yoga support group that people can engage in. All of those, totally free. And then for family and friends, self-care. Like, you need to take care of yourself. Annihilating yourself to the point where you're not taking care of yourself doesn't necessarily help heal somebody. It's a common thing to want to do, right? I think about a parent of like, oh my God, I would do anything for my kid. And, but doing anything doesn't necessarily mean solving something. And so with that, there's also the idea of like noticing what supports are in the community, and knowing that there's 12-step for you all as well. There's Al-Anon. That could be a great one. There's Codependence Anonymous. They could be really helpful. Talking about the difference between enabling versus support and help. Those are really good things to do. And the other aspect as well is note that this is a systemic thing. So if my wife is using substances, I don't want to sit there and be like, girl, this is your problem. Like that's not really going to be overly helpful. It's more of, I want to take that step back and go, and this is, I don't know if it's especially true, but even if she's not ready to take the step, it's an aspect where I go, you know what? Something's occurred within our family unit that that this is a symptom of. This, you're shedding light on this. And I'm part of the family system, so even if you're not ready, I want you to know I'm going to start doing the work for me, and I'm going to start doing work for our family, and know that you are always invited to join us in doing the work. And then for professionals, be ready, have screening tools, be educated on it, make relationships within the community so that you have referrals. I'm pretty cool, come talk to me. I'm more than happy to talk with you if you're like, I really don't know much about this. But make the connections in the community so that you could refer with confidence. That's what I'm always looking for, is like, whenever I'm referring to someone, I take it as like a part of me. Like, it would be if that person has a negative experience, that's a relationship that I have. So make those connections, be familiar with those self-help options, whether it be 12-step, 8-step, refuge recovery, Dharma recovery, the Phoenix, smart recovery, whatever it may be. There's a lot out there. Familiarize yourself with them. And then lastly, encourage the engagement of the family. If, once again, we want to address this as a systemic issue, and create a system of support, and so any ways in which you can do that, where it's safe and healthy to do so, is an awesome place to start.
Thanks, Danny. So that picture you're looking at right now, I picked it for two reasons. One, I wanted you all to see how great I look with a full head of hair, and that's really representative of what I was like back then. That's me outside of a nightclub in Ann Arbor, Michigan, where I'm from. I'd had probably 8 or 9 Long Island iced teas and a fistful of Xanax. And that was a normal Friday and Saturday night for me back then. And it's a great segue into my first experience with substances. When I was about 12 or 13, I was prescribed a benzo from a psychiatrist. I had crippling anxiety as a kid. In hindsight, I know why. I was 13, gay, in a small town in Michigan, and it was a different time back then. Public opinion had not shifted to be as tolerant as it is these days, and I didn't know how to deal with it. So these pills were my magic relief. They took away all the anxiety I had, all the thoughts I had, all the caring about my sexuality, just completely away. And pardon me. And I abused them from the get-go. People say they have an addictive personality. If that's indeed a thing, I definitely have that. I was on those until I was about 17, but when I was about 15 or 16, I discovered alcohol. I started swiping it from my grandmother's wine cellar. And I hear people talk all the time about the first time they got drunk. I don't know if I have that specific memory. I think I do. Whichever time it was the same story. I drank almost an entire fifth of whatever hard liquor it was. And it never occurred to me to use it as one or two drinks. That thought, it's up until the end of my drinking career, that never occurred to me. I just couldn't fathom why anyone would want to stop feeling like this. It made me personable, like you talked about. It made me, an awkward, overweight, gay kid in a small podunk little town feel comfortable, and it made it much easier to have friends. I suddenly had something in common with these other kids. It wasn't a healthy thing, but it was something I could talk about and do with them on a Friday, Saturday, if I'm being honest, Monday, Tuesday, or Wednesday night. I eventually ended up missing a fair amount of school because of those panic attacks in middle and high school, so I was a year behind. Still drinking quite a bit, not every day until way later. And there's one moment that really sticks out as a red flag. I don't know if they do it at every high school, but at my high school they do a senior walk where all the seniors get in their cap and gown and they walk around on their last day. I was a year behind from all these kids that I had grown up with and gone to school with, and got really depressed. So my solution, not having any coping mechanisms, was to leave school, go get alcohol and drink it. And I had no problem skipping school, like, ever. I don't know why in my head it was a great idea to go back to school on this particular day, but it was immediately caught and not expelled, but politely asked never to return. And it was a couple years until I was 20. It was 2 years until I went back and finally got my high school diploma and enrolled in a community college and did great that first semester, and then just didn't take it seriously. I had started working in restaurants, and if any of you work in restaurants, know anyone who works in restaurants, it's a party scene. We work hard, we play hard, we stay out really late doing drugs, drinking, sleep all day, and then go back to work and leave with a fistful of cash every night. Restaurants are great at breeding and cultivating young alcoholics and addicts. So remember let's fast forward a couple years. I do that until I'm about 25, 26. And I remember someone said to me that I was closer to 30 than I was to 20. And that freaked me out. So I decided I should probably take this school thing kind of seriously. I enrolled in that same community college, did great that semester, enrolled in a 4-year university, took 15 credit hours that semester, 4.0, straight A's, super proud of myself. And I was still working in the restaurant food service industry. I was doing catering. And after that semester, I thought, I deserve a reward. So I was working 2-3 days a week, making decent money doing it. And that's the summer where I went from misuse and abuse to complete dependency on a substance. There was something about that summer, maybe we can talk and dig into it a little bit, where everything just switched. And fast forward to the end of the summer, I was drinking every day. It wasn't quite in the morning yet, but it was mid-afternoon when I would start. I had 3 hours between classes on campus, so I'd go to the local Italian joint, sit at the bar, eat a Caesar salad, and wash it down with 3 or 4 Long Islands, and go back to class. And eventually that caught up with me that semester. I did a medical withdrawal and went to a detox place. This was my first experience with treatment. Was there for 5 days, 6 days. Within 24 hours of being admitted, I did have an alcohol withdrawal seizure in front of 150 people at a really big 12-step meeting. I don't advise doing that. Yeah, that was scary. I really put in perspective that I had more than just a drinking problem. People used to say, I wasn't alcoholic, I was a problem drinker, and I wanted to buy into that, so I did. They offered me to go to a traditional inpatient rehab place for 90 days. I, thought, I'm a smart guy. I can outthink this. So I declined and was promptly drinking, a couple weeks later. I kept it sort of under control. I just switched addictions to smoking a bunch of marijuana, and I did that for the entire winter semester, did well, and then the cycle starts to repeat again. That summer, thought I deserved a reward, I did so well, start drinking, fall semester, same thing happens. Go around to the next year, the exact same thing happens. Always did great that winter semester though. Around this time, my mom, a couple really good friends of mine moved to Colorado. I'd never been out here. Came out here to visit on spring break. Loved it, fell in love, went to Rocky Mountain National Park and was like, I want to spend the summer out here. So I came out here, and I'd been sober since the beginning of the semester. This is late April, early May. And a friend of mine drove out with me. We stopped at a hotel in Omaha, went down to the bar just to get food. I ordered that Long Island. You'll notice this is a common thing in my story, those Long Island iced teas. And I was off to the races again. Like, no time had passed whatsoever. I was back to, drinking almost a fifth a day, and I did that entire summer. Flash to August. I've seen this movie 3 times now. I know that I'm going to have to sober up, or the fall semester is going to be like the 2 before that. So I started going to a 12-step organization in Boulder, and I was sober for about 3 weeks and went back to drinking and went back to Michigan, and the cycle exactly like I've already explained. This time I reached out to my mom and said, this is what's going on with me. I don't think I'm ever going to be able to get and stay sober in Michigan. There are too many people, places, and things here. Through best intentions, someone would stop by my house with a 6-pack. I'd, of course, ask, where's the rest? There's 2 of us, but best intentions out the window, and I would relapse. And this was just such a common occurrence. She agreed to let me move out here and stay with her till I got on my feet, and she was going to pay out of pocket because I didn't have health insurance at the time for an inpatient 30-ish day treatment center. So time comes to go. It's New Year's, so I went up to visit those Michigan friends for one last hurrah. My mom didn't take too kindly to that and said she wasn't going to pay for it, so I didn't end up going to treatment, and I just kept drinking. And I never met a substance I didn't like, so I was dabbling in other stuff too. And then that fall I got my one and only DUI, and if anybody knows anything about DUIs, you can't drink. They give you UAs. I'm a pretty smart and crafty guy like most alcoholics, and I found out how I could drink a couple times a month, and I was doing like probability sheets to figure out what the probability would be if I drank on the 16th, and I was committed. When I got off probation a year later, I literally walked out of the probation office, learned nothing from this whole experience, went to a dispensary, got a bag of weed, and there was a liquor store next door. So I bought that fifth of vodka that I loved so much, and back to the races again. I drank a fifth a day for an entire year after that, a year and change, and then it's February. I'm out drinking with some work friends. They invite me to go back to one of their houses, and I did Molly for the first time after drinking more than a fifth and a bunch of Long Islands, and fell and cracked the back of my head open and got a bunch of staples in my head, and went to my mother and said, "Can I have that money? Can I go to treatment?" And she said yes. So I went to a 30-day treatment center. I should back up a little bit. I started going to therapy about 8 months before that, twice a week. In those therapy sessions, we were able to dig deep into the underlying issues that were causing me to drink, build up some coping strategies, mechanisms to be able to deal with emotions like a healthy person and not reach for a substance when things get uncomfortable. So I went to this treatment center, I think armed with the tools, doing some of the homework that I needed to do to set me up for success. I was there for 30 days. When it started to get towards the end, I was absolutely terrified of leaving that safe space. So I asked my mom for more money if I could go to a sober living facility in Denver. And I was there for 3 months. I think it was fantastic to have that extra layer of accountability afterwards. Drug tests, they make you go to, you can choose whatever program you're into. A 12-step meeting, you can do the recovery Dharma, you can get involved with the Phoenix, just as long as you're working some sort of program. And I did it. And then I got out, I enrolled in school, I kept going to those 12-step meetings. I got involved in those 12-step meetings. I currently am a trusted servant at 2 of those meetings here in Boulder. I finished school in 2 years, no breaks, no relapses, no medical withdrawals. I got a couple internships. My last one hired me, and I started working in the public relations field. Hated it, absolutely hated doing PR for B2B tech companies. So I reached out to AspenRidge after I had done some research. And I decided if I was going to leave my cushy, fancy PR job to switch to working in treatment, I was going to have to really buy into what they did. And what sold me on AspenRidge was that we treat the underlying conditions of addiction. It's not 30 days, hi, bye, we'll bill your insurance. It's, up to 9 months of treatment at gradual step-downs of care that Danny talked about to actually set people up for success, introduce them into a new sober community through the Phoenix or whatever they're into, whatever program works for them to get engaged. So I started working at AspenRidge. I've been sober for 4 years, 3 or 4 months, so a decent amount of time. The only addictive thing I do is I consume absurd amounts of caffeine, and that's about it. I'm a happy, well-adjusted individual, and I finally feel like that productive member of society that makes my parents proud that I wasn't for all those years. I hope you were able to take something away from this. If you're struggling, if you know somebody out there who's struggling, a loved one, a friend, they can get over this. It sounds cliche, it kind of is, but people can get help, and they can get better. Even if they don't seem like they're ready for it, I hear stories from Debbie, our reach clinician, about people who were court-ordered to go to therapy, and after a couple months, they're model clients who, are unofficially mentoring the younger folks in the program and stuff. So there is hope. It is a fatal and progressive disease, but you can overcome it. So thank you for listening.
And so, thank you for sharing.
You're welcome.
This amazing story. And there are so many like Steve's, and so if it's resonating with you, once again, if it's resonating with you personally or because you know someone, supporting them. And so this is what our continuum of care looks like at AspenRidge. We talked about PHP, the partial hospitalization. Realistically, I talked about generally in PHP, you'll get about 30 days. The reality is, PHP ties into day IOP for us, which is IOP for 5 days out of the week. And the idea behind that is we recommend 90 days of day program. And the reason behind the recommendation for 90 days is statistically, most relapses will happen in the first 90 days. And so if we know that, why not use that information to best support people? And then from there, steps to evening IOP, which is where we have IOP 3 days a week. We encourage people to do that for 90 days. OP, once again, encourage that for 90 days. And then we have an alumni program, and our alumni program never ends. It is a lifetime of support with the people that you've met. It's another aspect of fellowship, and once again I talked about community and that sober living that Steve talked about. You get it in 12-step, you get it in 8-step, whatever support group, but that aspect, that alumni community, it's so important. And I was talking with Mary, who's our alumni coordinator. I think they're doing a Super Smash tournament, which is they
did paintball recently too. They do really fun stuff.
Yeah, and I just want to go because I'm pretty decent at Super Smash, and I wanna show it.
And I want to get you in paintball.
You would.
Yeah.
I'm not good at that. And so these show nice, neat arrows, and that is our continuum. And I do also just want to encourage, real quick, we in our brains nice linear models. Sometimes it's not everyone's truth. Someone may feel most comfortable jumping in at outpatient or evening IOP, and they're going through it and they're like, something's not working. And with your treatment team and with case management, we are in that place of going, okay, well, maybe we need to look at a higher level of care to best support you, and then step back down. So it's not a one-size-fits-all. Not every story will look like Steve's. Everyone has their own individual way. And so the other aspects, as I talked about, we focus on the systemic aspect, right? This is a systemic issue. Trauma integrated, we want to look at all underlying aspects. We do brain spotting, which is a trauma-specific treatment. It has been so humbling to be able to provide that treatment for people and watch people's progress. We have psychiatric services, we have our alumni, and we have our case management. If you or someone is in need, please definitely check us out and know that our admissions team is more than ready to support you. You might even get Steve on the phone.
You might. Our admissions process is really quick, simple, and easy. Step one will verify insurance. It takes about 30 minutes to 3 hours to get that back, and then we can talk knowledgeably about what it's going to cost with your insurance. Any out-of-pocket fees, we can also work out payment arrangement too. We're pretty flexible in that area. We'll also do a 5-minute pre-screen with one of our client advocates. It's really quick and easy. It's a really basic history of any mental health issues, previous substance use, pretty standard questions. And from there, we'll schedule a 90-minute to 2-hour more formal intake assessment with Danny or one of our other program directors. And from there, they'll make a recommendation and work with you to decide which program is going to be right for you, which level of care is ready, is appropriate. And if you're ready, get you in as fast as humanly possible. Sometimes people leave Danny's office and they go right to group. You can contact our admissions team at referrals@AspenRidgeRecovery.com, or you can call 720-799-0050. That's 7 a.m. to 7 p.m. Monday through Sunday. We do have an after-hours call center, but they can still take your information down. I think that's all we have, unless there's anything else you want to add.
Questions.
I'm an open book, so ask away.
Perfect. Thank you both so much. Steve, congratulations on your almost 4.5 years of
Thank you.
sobriety. And you guys can hear me okay? Okay, so this is Amanda. I'm the disembodied voice. You saw me at the beginning of the presentation. I'll be facilitating the Q&A part of the evening. And so real quick, before anything with you fellas, someone asked if it was possible to get a copy of the PowerPoint, and yeah, please email me. I'll put my email address back in the chat, and it'll also be on the resource slide at the very end once we've done a few minutes of questions. But I will certainly add that to the chat once again. But one of the first ones that came in, it asks, do you consider regular use of marijuana an addiction?
Absolutely can be, yes. So there's socially, right, we get caught up in this aspect of what's socially acceptable. And so with legalization of marijuana, especially in Colorado, the reality is if it is checking those boxes for a substance use disorder and it has gotten to the level of compulsive behavior, absolutely. And like, it also doesn't even need to be a substance for addiction. Like gambling hijacks the dopamine reward system in a very, very similar way to substances. Even caffeine. Steve is popping off apparently with a bunch of caffeine, right? Like sugar, like these all are acting on the same system. And so it absolutely can be. And once again, when we go back to that concept of dual diagnosis, people are just different. And so, like for example, for some people, marijuana may not be an issue, and for other people, it really intensely, it could send them into mania if they have bipolar, and it could be very dangerous and disruptive to their life. And if they are engaging in that behavior compulsively, I'd absolutely call it addiction.
And if you're a Grateful Dead fan, absolutely, you're addicted to marijuana.
We have another one that came in. It's not a question, but just an FYI, which I love because we get a lot of book recommendations in the chats during these lectures, and people also ask for recommendations. So someone mentioned that a new book was written called One Big Tent, T-E-N-T, like camping tent, and it's for those that identify as atheist or agnostic, but still want to be involved in a 12-step program. But I'm wondering if you all had to make one recommendation to the audience for a book that can help people understand mental health and addiction or the treatment world, what would that book be?
Do you have one in mind?
I can give you mine if you want me to give it.
What's yours?
In the Realm of Hungry Ghosts is the one I always recommend by Dr. Gabor Mate to understand a lot of what you had talked about, Danny, the underlying and everything that precipitates substance use or any compulsive behaviors.
And the one they recommended sounds like a great read too. As far as I consider myself somewhat of an evangelical atheist. I'm hardcore. And one of the biggest struggles at first with 12-step programs was I mistakenly thought it was a religious program. I thought for sure they're all in churches. I thought for sure they were going to try and baptize me again. Wasn't into it. But they're not faith-based, they're not religious-based, especially here in the Boulder area with such a diverse community here. You know, people are Buddhists, atheists, Christians, and you can, if I can make it work for me, keep going, find someone who sounds like you or says something that you can relate to, and talk to them about any hostility towards religion or faith or beliefs that you have. I guarantee you there's going to be someone in the room who thinks just like you and also struggled getting through the steps because of that aspect of it.
How do you find a meeting?
You can go to aa.org. You can, if you're in the Boulder area, they're going to kill me for not knowing this, but if you Google Boulder County AA, they have a website. You can find those. If you go to na.org, you can find those as well.
Yeah, and that works nationwide, correct, to find those? Yep, that's a great place to start. Danny, were you going to add anything? I didn't mean to cut you off.
No worries. Just in terms of my recommendation, it's been a long time since I read it, and I can't remember the title. I believe there was one called Addict in the Family. It's a good book. I also would just really recommend and I don't know his book's called. I haven't read it, but Russell Brand is huge in the 12-step community, and I love listening to him speak and listen to his perspective on things. He has a wonderful podcast, and will talk with people about his experience. It could be really helpful.
Great, thank you both. So we have a couple questions about AspenRidge specifically. Do you work with youth 18 and under? Do you have an inpatient program, and do you accept Medicaid?
So we do not work with, we work with 18 and up. So we do not work with teens. I believe there's Sandstone that does. Also, in terms of support group, there's also Natural Highs in Boulder. It's a harm reduction model support, and so that could be really awesome for teens. Teens could also go to the Phoenix as well on other 12-step, gauge it for appropriateness. And in terms of Medicaid, we do not currently take Medicaid, but our Medicaid application is in, and it is part of our plan.
The next slide.
So Medicaid is on the horizon for AspenRidge, which I'm very, very excited about. And in terms of inpatient, we do not have an inpatient program.
Yeah, and I would also add to that just like how treatment isn't one size fits all, treatment centers are also not one size fits all. And thank you, Sandstone would have been my first thought as well. But so the resource slide should be popping up on your screen. Please don't hesitate to reach out to any of those email addresses. Myself, Shelby, Jen, who's the community outreach manager for AspenRidge. We're happy to help navigate. If AspenRidge isn't the right fit for you, then we can help figure out what might be. So don't hesitate to call or email. And that's true for Medicaid too, just to kind of give everyone an update in general. That's on the horizon for a lot of folks. It's just, bureaucracy, and it's caught up in the process. And then can you please repeat the name of the guy who does podcasts? I think it was Russell Brand.
Russell Brand.
That you recommended? Yeah, I like listening to him as well. And then there was one more thing I was going to mention. Oh, we just had someone that said thank you for sharing. I think maybe, Steve, that was meant for sharing your story.
I'm a big advocate of people in recovery being more open. I think the more we come out of the shadows and people see that we're sons and daughters, that it helps reduce the stigma. So happy to participate.
Wonderful. Yeah, thank you. I agree. I think the more we talk about it, normalize it, the less of an issue it will start to become, right?
Mm-hmm.
So we've got about 5 more minutes. Just gonna take a second, see if there's any more questions that come in. I had jotted some down during the lecture, but you guys answered all of them. So we're just gonna take another minute, see if people have any more thoughts or anything any more burning questions that they want to get answered before the end of the hour. Again, just to reiterate, the resource slide is up there. It's got the Colorado statewide crisis line for people who are experiencing crisis. You can call or text or go to your nearest emergency room for sure. And it's cut off there on the bottom, but Mental Health Partners here in Boulder also has a 24-hour walk-in crisis service. They're out at, I can't see the address, but they're out on Airport Road right next to the jail here in Boulder. So we don't have any more questions. Are there any? So I've got a couple closing words, but are there any closing thoughts or anything that you all want to offer before we wrap up for the evening?
Reach out. Ask your friends for help. Ask the people that love you. Give us a call. Give another treatment center a call. Just get the ball rolling. If you're thinking that you might have a substance abuse problem, that someone you love might have a substance abuse problem, just give us a call and we'll help you figure out if you do or not. And even if you don't come to AspenRidge, we'll find you another place that fits what you need. So even if people with Medicaid, Medicare, please reach out to us. We'll refer you out to another center and help you try and find a place that can help you.
Yeah, exactly that. And I think another piece too is a common theme is just knowing you deserve recovery. Like, that is really important for people to understand. This is something that you deserve, and it takes a lot of work, and it is achievable.
Wonderful. Thank you both so much. And actually, the timing was perfect about Medicaid and Medicare. We had a question that came in. Is there a low or no cost detox for those over 65 with Medicare? And I would make the same recommendation. Please reach out. We'll help. There's a lot of people. All 4 of us in this room are, ready and willing to help navigate what would be the right fit for folks. So with that, we have come to the end of our time this evening. Thank you all again so much for joining us, either for the live broadcast or for the recording. And the recording will be available probably early next week at bch.org/pillar, PILLAR. I'll add that to the chat again real quick. Also, for those of you that are tuning in live and that registered with your email address, you will be getting a follow-up survey. I would ask that you please just take 1 minute to fill this survey out. We do make adjustments to our presentations based on your feedback. And since we are a grant-funded program, this provides really strong data that we can show to our funders to continue to offer presentations like this one. Thank you all again. Thank you to our speakers, to AspenRidge, to Stone Cottage, and everybody that tuned in. Have a great evening. We hope to hear from some of you.
Thank you.
Thanks.